Hello. The video you are about to watch was recorded in 2005 in Chicago at the American Society of Plastic Surgeons annual scientific convention. This was a breast augmentation surgery panel of leading experts. You'll see that the video on my part addresses the issue of Gummy Bear form-shaped anatomical implants. And of course it was based on my significant experience already in the year 2005. Enjoy.
His thoughts with the use of many benefits which I'll discuss. Regarding size selection, first of course we do have to listen to the patient's preferences. Dr. Tibbetts and Hayden are correct in their pursuit of perfection by seeking exact implant selection algorithms, processes, but I don't use these algorithms. I find them too cumbersome. Here's how I do it. The height of the implant is determined by measurements from the inframammary fold to the upper edge of the patient's breast tissue. Patients with more subcutaneous fat do well with the taller implant. Thin patients with visible ribs have special needs and need a shorter implant. For thin patients, low-height implants remain natural, but the old tall implants were not. About width, the implant varies according to the patient's, the choice of implant varies according to the patient's desire for cleavage and lateral border of the breast. Larger implants, of course, extend further laterally and medially, and here I apply the patient's general size wishes. In general, we see great differences in projection requirements between parous and nulliparous patients. Young, small, nulliparous breasts with tight skin do well with an implant with less projection. In contrast, patients with ptosis or lax skin need highly projecting implants. Here, an extra projecting implant has been of great help in reshaping this breast only with augmentation and areola reduction. In the subglandular location, the highly projected cohesive implant has a remarkable ability to lift the nipple and act as an internal shelf for holding up the breast. The 510 implant is very exciting. The extra projecting device provides a firmer gel in a separate compartment under the nipple, and this firmer gel also assists in nipple projection. I want to ensure that my procedure does not interfere with potential future breast cancer treatment or sentinel node biopsy in the future. And so therefore I take the warnings of Sean's in plastic surgery seriously. Therefore I use an inframammary fold incision which facilitates dissection, hemostasis, implant placement, and is aesthetically acceptable to most women. The pocket is in a subglandulofascial location. The procedure is performed with the patient under laryngeal mask anesthesia. Local anesthetic is injected medially and laterally with a Klein needle before the incision is made. No cotton gauze sponges. The pocket is irrigated with saline only. Talc is washed from the surgeon's new gloves before insertion of the implant, and the implant size is determined preoperatively. I never use sizers, I never check the implants in the sitting position, nor do I change my mind intraoperatively. Cephalosporin antibiotics are used perioperatively, no drains are used, a couple of sports bra only for large breasts, and the patients go home after 6 hours of observation. The subglandular location is the most physiologically correct position because it increases the volume where the patient needs it most. A subglandular cohesive implant has a powerful ability to shape the breast. Also, as we've heard, breast distortion with pectoral motion is avoided. The lower breast may be filled without obvious upper pole bulge. This patient switched from submuscular round to subglandular anatomic. I do not follow the guideline that patients must have 2 centimeters of soft tissue thickness to qualify for subglandular placement. I find this requirement irrelevant after introduction of low-height implants. When the muscle and tissues are so thin that the sternum and ribs are visible preoperatively, I think we should reconsider the opinion that the muscle is going to hide the upper edge of a tall submuscular implant. On the contrary, even small breasts with their fascia can adequately cover a short implant whose height does not exceed the upper edge of the existing breast. This is one of the most important advances of the lower vertical height portion of the matrix. Although some patients desire the obviously exaggerated superior pole bulge, it's not my usual aesthetic goal. My goal is to have my patients tell me that no one can see that they have implants. I do not even accept that patients uniformly seek a straight lateral profile. Many thin patients with a short implant will readily accept concavity at the breast-chest junction without a brow. The desire to create a straight lateral upper pole profile does not justify submuscular placement in my view. Traditional reasons for submuscular placement are as follows. To hide the upper border of the implant, as I've said, short heights solve this problem. To prevent capsule contracture, the incidence of capsule contracture is going away for all kinds of implants in all locations. To prevent a visible implant edge, selecting the implant with the proper size solves this problem. To prevent a palpable edge, patients will ask about a palpable edge, but they accept it after you explain to them what it is.